Good afternoon, ladies and gentlemen. It's a pleasure to have you here. So we begin this instruction course on tackling posterior capsule rupture and IOL implantation. And we all know that, whenever we have these complications, it is not only the vitreous or the cortical matter or the IOL, or there are other complications also associated with that. So we are trying to cover up everything into this instruction course as much as possible. So, well, there is a slight change in the protocol of the presentation, and I think Dr. Namrata Sharma, she will be the first speaker, and she's going to highlight the complications, the corneal complications that are associated with the presence of vitreous into the anterior chamber. I invite Dr. Namrata Sharma to be the first speaker for this instruction course here, and it will definitely enlighten us. Over to you. Meanwhile, if you have any questions after the talk is over, we can have a brief discussion on that.
Thank you, Priya, and thank you for making me a part of this course. I would be talking to you about handling corneal complications in the presence of vitreous. Okay. There are no financial disclosures, and vitreous loss remains one of the dreaded complications of cataract surgery. The incidence of vitreous loss ranges from 0 to 19% in cataract surgeries, and it causes traction on the retina, which can lead to further retinal detachment and CME. So if vitreous is present in the anterior chamber, it can be present because of two reasons. One, because of the posterior capsule rent, and second, even because of the zonular dialysis. And when vitreous is present in the anterior chamber, there can be corneal complications in the form of vitreous endothelial touch. Sometimes DMD may be associated with it. And because of the corneal edema, there can also be poor visibility. Now, factors which cause corneal damage are immediate post-op EC reaction, which is prominent. What happened? The resolution problem. Immediate post-op AC reaction, it's again gone. Manipulation of the remnants of the lens nucleus in the AC and DMD, as well as anterior placement of the instruments, because one is scared when a posterior capsular tear has occurred. This may further jeopardize the corneal endothelium, and apart from this, there can also be surgically induced astigmatism and post-op IOP rise, which can again jeopardize the cornea. Now, the steps to prevent vitreous prolapse are that sudden withdrawal of the phaco-IA probe should not be done, avoid sudden AC collapses, fill the AC with OVD through side port and block the vitreous prolapse and stabilize any remaining lens material. And low viscosity and high dispersive OVD can be used to plug the PCR and tamponade the anterior hyaloid face. I'm sure the speakers that follow would be showing you the videos of this. The management principles essentially are that the wound has to be closed, and sometimes this could also become a problem, especially when too much of manipulation has been done in the presence of posterior capsular tear. Then one has to do adequate anterior vitrectomy, and simultaneous management of the corneal problems which are there, such as DMD, have to be done. So for the vitrectomy for the anterior segment surgeons, if you look at, we use vitrectomy cutter, and of course maximum possible cutting rate should be used with the lowest vacuum in the flow rates, which will reduce the traction on the retina, and preservative free triamcinolone confirms the presence of vitreous once the final vitrectomy is done. If there are focal vitreous strands which are not touching the endothelium, then intraop anterior vitrectomy can be done, and post-op one can observe. But if they are touching the endothelium, then focal, and if they are focal and peripheral, then they may be observed, and alternatively in the post-op period you can even do YAG vitreolysis. But if they are central, then always limited anterior vitrectomy has to be done. Now again, there can be blob of vitreous which is not touching the endothelium, and one may like to observe this or follow up these cases, or it may be touching the endothelium. Then in these cases, tricot assisted anterior vitrectomy can also be done. Anterior segment OCT is a useful tool, especially when you have post-operative corneal edema, and if it is associated with the Descemet membrane detachment, and if they are present in the superior half with the edges which are planar and not scrolled up, then one can use intracameral air. But if they are in the superior half with the scrolled edges, or they are in the inferior half, or extensively involve the entire cornea, then one has to use intracameral C3F8. Now just to show a few videos, suppose you do have a Descemet's membrane detachment, like in this case which came to us with posterior capsular tear. There was a Descemet's membrane detachment present and the corneal edema was there. The patient was in fact referred for a endothelial keratoplasty. And this was 2 months after the surgery which was done. And once you address this Descemet's membrane detachment with the gas which was used in this case, so that the Descemet's membrane gets opposed and attached, and subsequently over a period of time, the IOL is already sitting on the posterior capsular tear, but this does clear up over a period of time, and at follow-up 3 days only you have a small blob there, but it has definitely become clear, and there's still some amount of shallow Descemet's membrane detachment which is still there. So you can put another injection of the gas and it clears up completely without actually having to do endothelial keratoplasty in these cases. We've had cases where abundant cataract surgeries were referred, and we've published this. This was a case of abundant cataract surgery where vitreous prolapse was there through the open SICS wound. So closure of the wound was done, anterior vitrectomy was done, followed by the scleral fixated intraocular lens, and subsequently even desmetopexy was done because the Descemet's membrane was detached. So all of these were done in one sitting itself, and to take care of both the Descemet's membrane detachment as well as the open capsule which is there, and you can't put a lens, you can't put a single piece lens in these cases because there is nothing to hold on to it. As far as the DMD is concerned, this was yet another abundant cataract surgery case which was referred to us, and in this case, the Descemet's membrane, it was a complicated surgery. The whole of the Descemet's membrane actually came out, and then this had to be pushed back. So this is just a simulation to show that possibly the Descemet's membrane came out like this. The surgeon put it back again, and then send it to us after closing the wound. And 2 hours later, this case was taken up. It was very difficult to see which side is up and which side is down. So we did take help of the intraop OCT microscope, where the biceps curl upwards configuration means that the endothelial side is looking down. Alternatively, you can also stain it with the trypan blue dye before doing this case, and then can see what is the orientation of the Descemet's membrane. And then in this case the air was injected, and we call it autodemic because we've not used any other Descemet's membrane but the patient's own Descemet's membrane, which is just done it in such a manner that the orientation has been correct, and over a period of time it does function well because the time duration between the referral and the subsequent attachment was only 2 hours. Then you can also have incision site Descemet's membrane detachment which can occur, and we've published this saying that femtosecond laser incisions do have less Descemet's membrane detachment as compared to the conventional phaco. Preventing corneal edema is also important, and in these cases always the residual vitreous should be removed so that it doesn't touch the back of the cornea. Now, achieving circular and central pupil at the end of the surgery is important so that you know the entire vitreous is out. So this is the vitrectomy which is being done after the lens has been implanted in the sulcus in this case, and the myocol or pilocarpine can be put in this, followed by the vitrectomy which is done in the anterior chamber. And once that air bubble is there and it moves, it means that there is no vitreous actually present, and the wound is subsequently sutured, and it always is more satisfying if you make the pupils smaller as you end the case. Even if you have corneal edema in these cases, topical steroids, antibiotics, cycloplegics and IOP control has to be done and hypertonic agents have to be added. Now, we've published this corneal edema after phacoemulsification, and if it is late onset, it does require endothelial keratoplasty. If it is in the immediate post-op period, patient does get dissatisfied, and this has to be managed by definitive management, such as we can do use Rho kinase inhibitors in addition to the hypersol or the sodium chloride eye drops and sodium chloride ointment. And of course, if it doesn't really resort to that, then one has to do a corneal transplant. So to summarize, one has to assess the pre-op factors and do an appropriate intraoperative management, and of course in the post-op period also have to see that the cornea functions well. So thank you very much for your attention.
Thank you so much, Dr. Namrata, for this. I just have a quick question that whenever you have a case wherein there is an endothelial decompensation and there is already a complication and rupture and everything there and the IOL has been fixed, how much time would you consider to wait before you take up the case for endothelial keratoplasty?
So I think we should wait for at least about 3 months because you don't want you want everything to settle down. It should be a quiet eye and not an inflamed eye, so within 3 months it can be done. If it is, except in those cases we would like to wait for longer period if there's TAS, because those eyes behave differently. You may have a TAS-like reaction when you do a subsequent endothelial keratoplasty. So in those eyes where we are doing endothelial keratoplasty for TAS, we like to wait for at least 6 months.
Yeah. So is there any situation where you would consider it to do it as a one-step procedure? Suppose if you have a facility and you can fix up the IOL, would you consider doing any endothelial keratoplasty at the same time? No.
So we did do a study where we compared sequential versus simultaneous, and although you can do it, but the results of sequential were better than simultaneous.
Okay.
Yeah. So ma'am, regarding the Rho kinase inhibitors, would you recommend, say for example, instead of using hypertonic hyperzol or something, if there's corneal edema, would you recommend instead of using hyperzol Rho kinase inhibitors? Because as general ophthalmologists, we are a little worried that if the Rho kinase inhibitors cause toxicity, we can't make out in the early post-op period whether it's the drug toxicity or the cornea not responding.
So you would give Rho kinase inhibitors in addition to your hypersol, and not without it. It acts as an adjunct. Number one. Number two, it is 4 times a day and not 2 times a day when you're treating for cornea, unlike for glaucoma.
IOP, yeah.
And number 3 is it does help, and you can make out if your epithelial edema, which is like honeycombing, doesn't happen in all the cases, but that honeycomb pattern of epithelial edema is there, then you can make out that it is because of Rho kinase inhibitors and not otherwise.
Sure.
Okay. Anybody has any questions for Dr. Namrata Sharma, because she has to leave. So if there are any queries, you can please put up. Okay. Thank you so much. We now move on to our next speaker, Dr. Shail Vasavda, and he's going to talk about anterior vitrectomy, how to do a posterior capsular rhexis, and optic capture. Over to you.
Yeah. Thank you so much, Dr. Priya, for conducting this wonderful course. We do receive research grant support from Alcon Laboratories, but has no relevance to this presentation. So this was a 30-year-old male who had complaints of glare while night driving, and he was diagnosed as bilateral posterior polar cataracts, right eye more than the left eye. We prefer doing the femto delineation, which means we divide the lens into multiple zones or rings, therefore it acts like multiple hydro delineations without actually having to do that. And we followed all the principles that Dr. Bobby Osher has taught us over the years of maintaining a closed chamber, using low parameters, and making sure that the posterior polar part is not exposed right up to the last point. So here we are removing one epinucleus shell from the support of the other, so that until this last epinucleus plate is there, the posterior polar part is not exposed. Here what we are doing is we are just detaching this from the fornice, and this allows fluid to trickle down, which Dr. Bobby Osher described as the escape sign. So now even if you kind of come out and do hydrodissection, the chances of rupture are very minimal, because rupture occurs with hydrodissection when there is a raised intralenticular pressure. So here, because there is a communication created, you can still now go and hydro if it's a thick epinucleus plate. Make sure that you always inject dispersive viscoelastic before bringing out any probe. And fortunately, we followed all the principles. Bimanual irrigation aspiration definitely helps in such situations, so that there is less chamber collapse, as well as you can access everything on both sides. And fortunately, the capsule maintained as we hoped it would be, and we have a nice centered capsular axis. But sometimes when you do many such cases, you get overconfident, you get greedy, that there is this small little plaque and this is a young patient. Let me just pull out those fibers and they will come off. I won't touch it. And then you get greedy, and the moment I try to pull them up with vacuum, I've created this nice split, which we all dread occurring in a posterior polar cataract, which I could have easily avoided by not touching the posterior capsule. So now, since I've already done it, I still now have to go back and get calm again. So make sure that the irrigation is on, and I'm going to inject dispersive viscoelastic at this point of time, because dispersive viscoelastic is one which stays. So cohesive viscoelastic, which is like sodium hyaluronate, can come out as a bolus as soon as you bring out the irrigation. Once I've made sure that the chamber has been well formed, I have this slit tear, which I still have an option of converting into a posterior capsular axis, because it's still very much within the central capsular axis area. So it's not gone up to the equator. So now I'm injecting cohesive viscoelastic because I want some weight on that posterior capsule and pushing the anterior vitreous face down. This is the time when we need micro instrumentation. So these are micro incision rexis forceps. Grab one end, because these edges are the ones which can split. So you want to convert these edges into rounded edges, so that they will act as strong margins for capsular rexis. So I've started from one end, and I couldn't unfortunately, reach and completely cover the other side. I finished a little bit in front, so I have to now make sure that I go ahead and convert this edge also into a rounded capsular axis margin. So I'm gone through my other side port, making sure patient is under topical, so using a spatula to control the globe position. And now I've converted both those edges of the PCR into a posterior capsular axis. So this will now act as a strong margin. It is almost like an anterior capsular axis. So now, since there is no vitreous disturbance, we can go ahead with our plan of in-the-bag IOL implantation, which in this case was a trifocal which was planned for this young patient. So we go ahead and place the IOL inside the capsular bag. Here it's important to have an IOL which opens up slowly, so you have sufficient time and it doesn't open up in a jerky fashion. And once that is done, you make sure that the haptics on both sides are behind, and as luck would have it, it was also toric, multifocal toric. So through my microscope, I am looking at the digital alignment system and making sure that the IOL is aligned to its appropriate axis. Obviously, you are not going to be foolish in going behind the IOL to remove the viscoelastic in this situation. And post-operatively, you can definitely go ahead and give mannitol to such patients to dehydrate the vitreous and whatever viscoelastic that has gone behind this posterior capsular axis. And this is the on-table picture, centered IOL with a centered capsular axis at an appropriate place. And this is the patient doing now 6 months, almost a year down the line, well centered. The IOL has not rotated, and he is going to maintain a clear visual axis for the rest of his life. You do monitor these patients for macular edema and peripheral retinal breaks, which fortunately didn't occur in this patient. So the most important lesson that I learned was that never touch the capsule of a posterior polar, however many lakhs of surgeries that you may have done. When there's a small PCR, you still have a chance of converting into a PCCC and before it enlarges further. So having learned the lessons from the previous case, I approached the second posterior polar cataract, and this is even more risky. You can see these granules all around, which means there's a higher chance of creating a capsular rupture in this case. So I followed all the dictums, all the principles, went ahead with flax. Fortunately, right now the capsule at least appears intact. We went ahead with the multiple ring pattern division. And the surgery went off perfectly, and I followed what my learnings from the previous case of not touching this plaque. I can always yag it later. So now I'm going ahead and injecting this IOL, and I'm struggling a little bit. If you noticed here, it's kind of the cartridge has actually come out of the wound, but I think I can still manage. Once again, I think I'll go ahead, I'll push it back in, and I'll be able to do it. And oops. So not only did the IOL get stuck, I also had a dip of the IOL, which means it touched the posterior capsule, which I wanted to avoid touching. So now in a panic mode, what do I do? So the first thing is I don't want to try and push or pull this IOL again. So I thought, let me just enlarge this incision a little bit. So I'll release the stress on the IOL. So at least I can safely push it in and see what the situation is right now in the other part. Once trying to do that, I do realize that there is this large capsular dome that you see here. That's the PCR that I've created. So now I am in a fix. I have a single piece IOL, 3/4 of it is inside, one haptic is outside, and I have a PCR. So the first thing that I'm trying to do, having learned from the previous few cases, is to try and convert this ragged edge into some sort of a strong margin, so that even if when I do vitrectomy or if I try to do something with the IOL, whether it's explant or doing it, at least I have a strong margin that it doesn't extend further. So I've picked up this flap and I've converted it into a rounded edge, which means at least one part of this area I'm sure I'm not going to extend further. Now I know with so much of manipulation there is likely to be vitreous in the chamber, and therefore our approach is to do a pars plana approach, and to insert a trocar in an open eye is not easy. So you have to suture the wound and make sure that the eyeball is tight, and you go 3.5 millimeters behind the limbus, and you do need a little bit of force, but it does tend to occur. So I've made sure I've kind of inserted the trocar. And this flap from the other side, fortunately now I could visualize. I've also made sure that I've converted that also into a strong margin. So now my chances of extension of this tear are very minimal. The only way to identify the presence of vitreous is to inject triamcinolone. And you'll notice the advantage of pars plana, that with the irrigation from the front and using the vitrector from behind, you'll see that there is no turbulence that is occurring, and this entire blob is getting drained through this PCR, and slowly you'll see that this flap will start fluttering in the AC, which means the connection between the anterior and the posterior component will be severed. Because very often when you approach from the limbal route, you do tend to drag out more and more amount of vitreous from the anterior chamber. So I've made sure that I've severed the connection between the anterior and the posterior vitreous connection, and you'll see this now flap of vitreous which is stuck in the incision on one side, but it's floating. I'm just using the irrigation to highlight that it's now severed from its posterior connection, and now therefore you are unlikely to disturb more vitreous, and this further you can just remove it from the incision from whichever way is more appropriate. Further, we do a further vitrectomy not just in the area of the PCR but all around, so that symmetrical amount of vitreous is removed from the area of the PCR. This is all viscoelastic dispersive, which is quite difficult to remove. And now at least I have a strong capsular axis, and now I can think of converting this, putting this IOL in. I'd like to credit my colleague Dr. Samresh, who brought out this wonderful teaching video to show that when you approach the vitreous from above, that is the top-down approach, you are dragging more and more amount of vitreous, and what started as a small PCR typically ends up being a large, ragged, irregular tear, which becomes very difficult to convert. Compare that to the pars plana approach, where you're dragging the vitreous from where it's actually coming. you're attacking less amount of vitreous and it drains through that area of PCR. So you can notice very little turbulence, very little change in the site of the PCR. So that's something that I learned. Now I want to make sure that I put the IOL inside the bag. So I'm making sure my visibility is good. So I'm using iris retractors in this area to confirm that the PCCC is complete on this side. So again, a take home message is do not hesitate to use whatever is needed at that point of time. At this point of time, I needed iris hooks, so I used the iris hooks. And here I am gently making sure that I push the optic haptic junction behind the anterior capsular axis and making sure that it remains behind and making sure all around that the IOL is in the bag. Always reconfirm after any manipulation that there has been no further vitreous disturbance, which fortunately there wasn't in this case, and hydrate all the wounds before the chamber collapses again. Take as many sutures as needed. This is not for aesthetics. Whatever it takes, you do it. And this is the patient now more than a year down the line. This is the PCCC that you see. There was a dent in the IOL. The plunger had overridden on the optic and therefore it got stuck. Fortunately, it's out of the visual axis area. There is some PCO that is developing in the intact capsule, but so far hasn't required a YAC capsulotomy. Coming to this, another case of a 42-year-old male scheduled for second eye multifocal IOL with a query posterior polar. Once again, things have gone off very well. And now I'm injecting the IOL, and if you notice, I hesitated a little in injecting, and the IOL has just become a little vertical. But it's in the cohesive viscoelastic, so I've managed to make sure that it goes back again, and there is absolutely nothing that has gone off which I think is inappropriate. So IOL is once again in the bag. This is in retrospect. Having analyzed this video, this blob appears suspicious, but I could never notice that on table. So since I thought everything is perfect, I go ahead with my normal technique, irrigation behind the IOL to make sure that all the viscoelastic gets driven out and we have an empty posterior bag. And that was the blob that was missed, and now I have a single piece multifocal in the capsular bag with a tear extending up to the equator on one side and on the other side, second eye. So now what do? First of all, you pray that nobody has seen this and this has not happened. So that's what I did. I hydrated the wounds and I thought God is kind and this IOL will center. Nothing has happened. So I tried centering the IOL, didn't work. So eventually I had to take the decision, injected triamcinolone, and obviously with so much of currents of irrigation aspiration, the vitreous was disturbed, as you can see, and it's coming from the area of the PCR. Whenever there is vitreous, you have to attack it, and the best way to attack it is through the pars plana. And you'll notice once again the advantage is that I'm draining it from the area of the PCR, and slowly but surely you'll see this vitreous getting sucked in beautifully through this PCR. Although it's not, at that time it didn't appear beautiful, but we are making sure that the vitreous gets drained through the area of the PCR, and slowly but surely once again you'll see this flap fluttering up again, which means the connection between the posterior component of the vitreous from where it's coming and from the anterior is getting severed. So make sure that once that is severed, you can remove it from the incision from whichever place you like to, and then go back again and do further vitrectomy all around the PCR to make sure that symmetrical amounts of vitreous is removed from all sides. It looked stable on table. I'm still praying for the next day to see how this eye is going to behave. Fortunately, we had counseled her for all possible things, and being a second eye, we were a little more relaxed that we have the patient at least with us. This is 7 days, this is 3 months, and this is 6 months. Even the rest of the capsule has remained clear. PCR extending up to the equator, very well centered in the bag IOL implantation, and that's because of adequate symmetrical vitreous removal from the pars plana all around. And this is the UBM of the same patient at 6 months, showing no tilt of the IOL. The IOL is very much in the bag and no internal aberrations, which means even clinically the tilt is minimal. All of these patients need to be monitored by a VR surgeon. You want to make sure at 1 week, at 1 month, at 3 months that they indent and see at the periphery to make sure that if any break event has started, that can be handled or tackled at that point of time at an early stage before a retinal detachment occurs. And these patients are more likely to develop cystoid macular edema. So don't worry about as many times as you may have to do a free OCT for this patient, as many times as required in the follow-up. And this is what I meant by removing symmetrical vitreous from the pars plana approach. When you're doing from the limbal, however much you may change your hands, it's very difficult to remove equal amounts of vitreous from around the PCR, and therefore you leave behind unequal pockets of vitreous, which eventually leads to subtle tilting of the IOLs and other inflammatory components. Whereas when you are approaching from the pars plana, you can not only drain the vitreous from there, you have much more ergonomic access to all around the posterior capsular tear, so that you can remove symmetrical vitreous from all around, leading to a more stable IOL. I can stop wherever yeah, okay. So this was a 65-year-old male, right eye cataract surgery done in 2017, now planned for the second eye, grade 1 nuclear sclerosis. And everything seems to have gone off well. We are doing the irrigation aspiration removal, cortex removal with our bimanual technique. And if you notice here, while doing this, I can see a little kind of line here appearing, which is far too clear compared to the rest of the capsule. So this is something that's already a warning sign appearing, 2 lines. The rhexis is intact, but this is a very, very clear area that is there, and you can notice some shadows appearing as well. So definitely the capsule has been breached in this area. And the surgeon is still little oblivious of the fact that this event has occurred, and things are going off as per routine. Finally, it seems that things have been noticed, and you can notice here now you have an equatorial PCR, some amount of viscoelastic, maybe a little bit of mixed with pigments or something is already there in the anterior vitreous phase, with an intact capsular rhexis. And this patient is planned for a single piece IOL for his second eye. Wherever and whenever there is a vitreous disturbance that you suspect, you must tackle it at that point of time. And even this was a 2.2 millimeter incision. I sutured that wound before I made sure that I injected the trocar so that the globe is relatively well formed. You need a good anesthetist because this patient was under topical anesthesia, so he was sedated more. And once again, in the area of the PCR and all around the area of the PCR, keep a very low bottle height, a very low flow rate of 10 cc, and a vacuum of around 200 to 250, and have the maximum cut rate that your machine offers, whatever that may be. Here it's 5,000, it could be 2,000, 3,000, whatever the maximum cut rate that your machine offers, go ahead. You don't want to get very close to the intact posterior capsule because you can cut it very quickly if you're not used to doing a vitrectomy. So angle your vitrectomy probe a little bit more posterior. But you do need to remove vitreous even around this PCR. So the PCR is here, I'm removing some vitreous below the anterior, intact posterior capsule also. And once the vitreous has been tackled, you can go back to your bimanual irrigation aspiration as well. Since this patient was planned for a single piece, I know, equatorial PCRs are very notorious. So my plan right now is to try and put the IOL in the bag and orient the haptics in the other direction so that I can get away with that. But even with that, I'm finding that I'm probably not going to have a very stable IOL position. So having placed the IOL in the bag, I'm going back again and making sure that I once again remove any vitreous connections that may have occurred during my IOL manipulation. So going ahead in the area of the PCR and around the PCR and doing an adequate vitrectomy. And once that is done, to improve the stability, I'm thinking what can I do to make sure that this IOL doesn't move or it doesn't dislocate with time. So I'm going ahead with what I've learned actually from Dr. Priya Narang, with whom she published reverse optic capture. So this, in conventional optic capture, you have the haptics in the sulcus and the optic captured through the anterior capsular rhexis. In the reverse optic capture, you have the haptics in the bag and you are trying to pop out the optic above the IOL. because a single piece IOL cannot be placed in the sulcus. The haptics are too bulky to be placed inside the sulcus. So I put my irrigation probe behind the IOL, and with my Lester hook I am making sure that I am kind of bringing the optic first in the center and then trying to pop it out above the anterior capsular axis, and you will see this broad band, unlike with a 3-piece IOL where you see a very narrow dumbbell kind of appearance. Here you will see a broad band because the optic haptic junction is very broad in a single piece IOL, and it is challenging to perform, particularly if your rexis size is on the relatively larger side. Fortunately, I found that the capture was remaining stable. This is the PCR and this is the reverse optic capture with the haptics inside the capsular bag. Post-operative day 1, except for the areas of subconjunctival hemorrhage, the eye looks very quiet and clean, and except for me and my assistant, nobody knows what happened. The patient doesn't know what happened, and this is the reverse optic capture. You can see this area of the PCR which is crystal clear. Rest of the PC will develop early fibrous PCO, which you can definitely YAG as and when required. And this is the broad area of optic haptic which has got reverse optic captured. Patient did quite well. This is the anterior segment OCT to show that the optic is still very much behind the iris, so no chances of uveitis, glaucoma, hyphema occurring. So pars plana did come to the rescue, and reverse optic capture of a single piece IOL, although difficult, is possible, and I think it's an important tool to have in a surgeon's armamentarium.
Thank you so much, Dr. Shell. That was so enlightening. It was a wonderful talk. Well, I have 1 or 2 questions for you. Could you just highlight the instrument that you use to do a posterior rexis?
So it's nothing fancy. It's a micro incision capsular rexis forceps, which we actually designed with Indo-German. I don't know what name they call it in, but it's a micro incision capsular rexis forceps with no financial interest. We use the one made by Indo-German.
Okay. Yeah. And for the optic capture, I would just like to, for the benefit of the audience, I would just like to say that having what Dr. Shells showed was real beautiful, but it is actually difficult to do it with a one-piece intraocular lens, because you know the moment you try to bring this and try to capture it, if you do it from one side, it slips from the other side, and eventually it goes back again. So, and as Dr. Shell highlighted, the size of the capsular rexis is very important. The bigger it is, the
absolutely. So you need a very, if you find that your capsular rexis is large, do not attempt it, because it won't stay. Even if you think it is stayed on table, the moment the IOP in the eye changes, it may decapture and fall back.
Absolutely. And actually, whenever we have all these cases, you know, where we are doing an optic capture and settling up things, and whenever there is a vitreous and we have done vitrectomies and all that, whenever we hydrate the wounds, you know, before you leave that, you close the eye, you know, you should have a brief outlook of what actually it's looking like. It should be stable at that point of time. If you have a 1%, because we all have a sixth sense coming in that, okay, this might have a problem later on, it means it will have a problem. Absolutely. There is no way that it will not have a problem. When you leave the patient, you should have a feeling, now this is going to be okay, nothing wrong with this right now. So I think that's very important. I would like to invite audience for questions to Dr. Shell. Meanwhile, Dr. Lalit Verma, sir, could you please go ahead with your next talk? So, yeah, yes, Dr. Gadre.
Yeah, Shell, as usual, wonderful talk. I was just wondering, in that particular case where this is the second eye where you are doing panoptics.
Yes.
And there is a posterior capsule rent. And unfortunately, even the anterior capsule is torn at a point.
Yes, sir.
And you have placed the lens, and unfortunately next day the lens is in the vitreous. The other eye has a panoptics. Now, have you or anybody tried putting panoptics in the sulcus? Because the modern lenses, the Clarion lenses that we implant, the loops, as we all know, they are not as thick as the previous one, and secondly they are extremely soft, because they are almost like the hydrophilic haptics. So is there any experience of putting panoptics? Because you have done panoptics in one eye.
Correct, sir.
Here you have to remove the lens. You don't have a 3-piece trifocal available. You just can put a monofocal in the sulcus.
Correct,
but then you have to do a lot of explaining later on. Fortunately, as you said, one eye you have done yourself, so patient is understanding and all that. But we had one experience and we are following that.
Okay,
Now it's more than 2 months, and 2 months is a very short period for these lenses to
Correct,
create
sir.
mischief. So I just want to know, I haven't seen anybody in the literature doing a panoptics Clarion lens in the sulcus. But right now the eyes are absolutely quiet, and surprisingly there isn't much refractive surprise as well,
Okay.
because the anterior chamber is deep, it hasn't shallowed or anything, or there is no pupillary block. Even your comments, Priya. Can
Maybe
you-
with the newer materials, we might still have to evaluate that. But
Yeah.
as far as the general rule goes, never put any lens
I know,
which has
I know.
Yeah,
which
yeah.
has an acrylic thing.
That
Never
is-
put it in the
Correct,
sulcus. Believe me, before I came to the conference, one day before I have explanted an intraocular lens, surgeon had probably put it into the sulcus with those acrylic lenses. They are just not forgiving to the sulcus.
This-
So I don't know about the Clarion
This
as you are
material
saying.
looks different. This
Yeah.
is Clarion
Maybe
material.
it needs
is-
to be evaluated.
Yeah, I mean, no
And-
personal
Yes.
experience of single piece.
Yeah.
And because Dr. Lalit is also here, there is one question I always feel when I listen to your talk. You always say that when you're doing a pars plana vitrectomy,
We will
you
come to
have
it.
you have a symmetrical cut all around.
I think
Now
we will
you
talk
don't
about
see it. Actually, what you are doing, you are seeing only in the pupillary area. And how can you be sure that you are doing more
Symmetrical.
vitrectomy on one side than the other?
So, sir, that's true. There is no end point as such that we can judge. But at least if you stay there, if you keep a mental clock in your mind that 10, 15 seconds here, now 10, 15 seconds next point, 10, 15 seconds third point, you try and at least follow that principle of doing a
Sanjay,
circular.
you are
But
Absolutely,
vitreous at that particular age is degenerated.
Correct, sir.
It's floating so freely. If you have, intraoperative sonography, you would realize that the vitreous is moving, dancing away. So it would be a myth to propagate that we are cutting vitreous, surrounding all the areas. I accept all other
I agree,
points.
agree. So I
that you
think
said.
that's an extremely valid point. This is something that we feel we are doing better with this approach, and probably not all vitreouses are so liquefied. Quite a few of them do have some jelly as well. So, but I think I agree with your point. There is no evidence or there is no proof.
I would like to settle this. There is a VR surgeon and there is an anterior segment surgeon. So the anterior segment surgeon will try to cut off everything that comes up into the pupillary plane and slightly behind it. They won't be going beyond that. So as a VR surgeon, you and Dr. Lalit,
Sanjay, your observation is absolutely correct.
Yeah.
You see, this is a blind kind of vitrectomy. We do not see the vitreous unless it is stained with
Stained.
triamcinolone.
Yes.
Therefore, Shell was very nicely emphasizing in the anterior segment, yes. Even in the posterior segment, unless you put triamcinolone, you do not. And sometimes you have to repeatedly inject that. And the only thing is he is stressing on symmetrical this thing. It may be asymmetrical, but still it is better than doing it from anterior segment.
Absolutely.
I 100% agree that you see gel is there. Every vitreous is not a sol; it's a gel component there.
Yeah.
So thanks.
Thank you so much,
thanks, yeah.
Dr. Shell, and I invite Dr. Lalit Verma, sir, and he'll be talking from the perspective of a posterior segment surgeon, that what anterior segment surgeons should not be doing.
So thank you, Priya, for this very informative course. And you see the hall full means your success. And she has been doing this course repeatedly, and we keep talking about the same things, emphasizing the role of vitreous. And thankfully, Shell has covered everything what I wanted to speak. In fact, it looked like he is more of a VR surgeon than an anterior segment surgeon, because he was going through pars plana. And some of the videos I have taken from YouTube, that red colored vitreous, I have taken from YouTube only. So, chal rahi hai? Chod. Okay, we'll start with the. Yeah, thanks. I'll talk about PCR. This wonderful venue, I'm thankful to that. PCR does happen. This has been stressed again and again. It happens during the learning phase because surgeon is not experienced, or it happens because of a busy surgeon who's overconfident, who wants to do, in 1 hour 10 surgeries. It generally happens once you are in a hurry or at the fag end. This is what referral we get. Doctor, I was doing completely, last bit of it went away and we don't have machine and therefore referred. This is usual complaint which the patient comes to us. But issue is not of PCR, and Shell has very nicely described how after months and years also this lens is well centered. Issue is how it is managed. Whether you are doing a cursory kind of vitrectomy or you are not doing vitrectomy at all. So I'll just show 1 or 2 videos. This may be some overlap. This is one patient who has had PCR, and you see what is being done. The wound is slightly enlarged, and then here comes the infusion. This has been emphasized, it should be a low volume, and as Sanjay was saying, what is being cut, we don't know. With the help of cutter, wo andar to chala gaya, but it's not what is happening, we don't know. So this is what we call a blind vitrectomy. You don't see what you are doing, and you're doing a blind vitrectomy and consoling yourself kar diya, and you put a lens inside. Believe me, this eye is doomed for GRT or whatever for lifelong, and you have to keep under follow-up. So that is what is the curse of PCR. Another video of another surgeon actually. You see here there is some air bubble here. So this is a nicer thing. At least after that PCR he has bothered to put tricot inside. And with tricot has the property to get adsorbed onto the vitreous fibrils so that they are seen. And now it is a definite. You see all this vitreous here. So this is being cut. Like he said, severed, because the connection between the anterior and the posterior should get severed, so that we want there should be no traction onto the anterior base. So this patient is less prone for posterior segment complications as compared to the first video which I had shown. So IL is already inside, but that vitreous, I think whatever was there in the anterior segment has been taken care of. Is this enough? So if you do not have VR support at hand, or you do not know the job of vitrectomy, best would be to put some tricot and do this, what I was showing. You can still, if you have done an anterior segment vitrectomy with the tricot, can still go ahead and put on the anterior capsule this bag, but ensure that wound is secure, and then maybe follow-up can be done by a VR surgeon. Aim is that there should be no vitreous and should be a nice round pupil. That is, I think, the end of the end point of doing a good vitrectomy. And never pull the vitreous. And do not do a blind vitrectomy, which I think Sanjay alluded to very nicely. And for this, Sanjay, one suggestion is that if you have an old cutter, it will suck, not cut. So most of the anterior segment surgeons will never have a fresh cutter. So best is to have a good cutter, even at the cost of increasing the expense. A good cutter will definitely cut in the presumed area rather than suck. So old cutter will suck and not cut. So good cutter, hand-hand infusion, slow infusion, because if you have fast infusion, it will hydrate and push more vitreous. And leave as much as rexis, both anterior as well as posterior, there so that lens can be supported. And as Priya was saying, do not go deep. Have a horizontal plane of action rather than as an action like this. If you should have a horizontal plane of this thing. And just behind the iris plane, keep doing the vitrectomy. So messages in the event of crisis, and believe me, these 5 pictures I have taken from my own where vitreous was not properly tackled. In the event of crisis of this PCR, and in case you want your patient, like Shell was saying, to be stuck with you or follow with you only, respect the vitreous. Respect the vitreous, if not the VR surgeon, at least respect the vitreous. Because this will actually help you. And believe me, this patient does require long follow-up. He showed indirect OCT, free OCT, you have to keep doing. Otherwise, believe me, things like this is a GRT, this is a detachment, this is a CME, media haze, this is PVR. There are more examples like this, but I thought I'll show you this is a reality. This is not a myth that I'm speaking from here or Shell or Priya. This, you have to respect the vitreous. So why this colored vitrectomy, which I said chromo kind of vitrectomy, is because clear vitrectomy is difficult, in clear vitreous is difficult to see. Because believe me, it's a specific science. You have to see and cut. You have to see and cut. Then only vitreous can be cut. So therefore, triamcinolone gets adsorbed onto the vitreous fibrils and makes vitreous easier to visualize. Otherwise, believe me, you are right that you are doing a blind kind of vitrectomy. And this facilitates complete job, precise job, and maybe time taken also is less, that you are not inside for a long time. Because you know what you are cutting and you are seeing. And also reduces the chances of complications, because you have done a complete job and precise job. This is about pars plana, which I think Shal did emphasize, and even at the cost of repetition, I will speak about this PCR, and this is the PCR has happened, and surgeon doing a vitrectomy again with the health cutter, a blind kind of job being done. You do not know what is being cut. It's basically time pass kind of job which is going on, and this is vitreous getting more hydrated also, and more vitreous gel will prolapse into the anterior part. This is what Shal also showed, and I copied this from YouTube of Vasavada, where if you do it from posterior segment, you are pulling it inside. But if you do from anterior segment, you are making it larger. There is a possibility that it will increase. So you see how ragged, I think I will not repeat this. So I will take you to this patient who had surgeries being done by our colleague, a traumatic patient, traumatic cataract, where there was, the patient had been spoken, there is a possibility that there may be a pre-existing PCR because of trauma, because on ultrasonography he could not. So, but because surgeon was confident and went ahead. So at this time he gave up because vitreous was admixed. If the vitreous is admixed with the cortical matter, no matter what you do, it will trouble you. It will trouble you. So we go from pars plana, clean up the lens matter, and there is a big PCR there. Try to take time, don't be in a hurry, because if you are in a hurry, then you may disturb this capsule also. And the whole job of optical rehabilitation then will go for a 6. So take time, sometimes engage the cortical matter and pull it slightly rather than always cutting. So it's a combination of dragging the capsule, dragging the lens matter with the help of suction only, and now it's a reasonably complete job done. This we had copied that, wherever there is an enemy, you should have to strike that rather than, and then this lens was put. So limbal root carries the risk of extension, traction, residual vitreous, whereas through pars plana, although there is always an inertia or hesitancy, the possibility of extension of PCR, traction onto the retina, and possibility of complete removal of vitreous is this. So we should get away from that thought block that anterior segment surgeon can't do it. Believe me, all of us have to learn this trocar cannula system. It's not difficult at all. So, as I said, the first thing is avoid the first upper left corner. If you are not confident, do triamcinolone assisted vitrectomy from anterior segment, and best is to learn the trocar system, and vitrectomy for the pars plana is more definitive, or possibility of complications is much less, and avoid complications like this. So pearls are that do not chase the lens matter also in the vitreous. Suppose lens matter has fallen with a phaco probe. Believe me, if there is a PCR, if you put a phaco probe through that with the hope that this will swirl up and come into my probe and then I'll take it out, don't do that, because you are not respecting the vitreous. And do not attempt to do that irrigation and float up this lens matter. And never use this deadly instrument like this, which vectors like this, and try to pull. You see, this patient has a vitreous loss, and what is being removed is this kind of sweeping the vitreous is most dangerous. And this, putting this vectis inside, just an attempt to salvage or attempt to salvage this nucleus, this will not. Now this McPherson forceps, what we are pulling is vitreous actually. Therefore, this will not come out so easily. It will not. You are increasing the traction. So don't put this ghastly kind of deadly instruments inside the eye to, salvage this nuclear piece inside. So these are not mandatory at all. And what you will see next is this this motion of sweeping the vitreous with the help of swab stick, which again has to be discouraged. So believe me, lens matter has never damaged the retina. It is surgeons who damage the retina. It is we who are to be blamed. So forget about this idea that lens matter is going to damage or UV weight. All these are possible to control. You could use viscoelastic to create a barrier. In performing anterior vitrectomy, never use cellular sponge to remove, and do not sweep this wound because here there is a big vitreous. Believe me, this will instantaneously cause peripheral traction and possibility of GRT also. So this is what I was stressing, that do not do this. You can use a visco expression if required, but I am just searching for that sweeping movement of the vitreous with the help of this this thing. This is to be totally discouraged. So even at the cost of repetition, let me show you again. This should not be done. This is deadly. This should not be done. So for lens matter which have dropped into the vitreous cavity, first action should be wait, pause, relax. Am I confident that I will do it? Believe me, all dislocated matter may not immediately require intervention, and prefer a pars plana approach for vitrectomy for removing all these things. Believe me, there has to be good visibility also. There is no urgency. There is no urgency to remove that in the same sitting, except that you have promised the patient that you will do a sutureless job. So this is another patient who had PCR, and the lens matter is still inside. Sorry for this bad quality of video. So then you approach this patient after a couple of days when cornea is clearer. Studies have shown that it does not matter if you wait for a couple of days. So even if the lens matter has fallen behind, we do not go to the lens matter immediately. We first go around and around, remove the vitreous, and then once it has been, we are now taking course of phaco-fragmentation, and with the balanced, suction and phaco power, after the vitrectomy has been done. You see, aim is not to go towards the nucleus immediately. Aim is to first do a vitrectomy and then remove this nucleus once it has been freed from the surrounding. And then, with due respect to the anterior capsule, you suck this or peel this cortical matter, which comes very nicely, and then insert a IOL in the sulcus. This is another patient who had problems with the surgery, and we did plan, because other eye was pseudophakic, we didn't plan a glued IOL which has been mastered by Amar, Priya. They have written books on glued IOL, which I think all of you should read. So this is planned for glued IOL in any case. So we had, this vitrectomy to be done first and remove this matter from the anterior segment so that the visibility in the posterior segment improves. There is cortical matter, there is nucleus piece there. So aim is not to remove this white matter first, aim is to sever these connections between the lenticular matter and the vitreous. Do a vitrectomy as good as you can. Aim is to, remove the traction onto the vase. And once that has been done, then softer part will come with the cutter itself, or sometimes you have to feed with the help of light pipe into the mouth of the cutter. So remember, this vitreous has to be cut first, what you see here. And after you have done a reasonably good vitrectomy, you see this lens nucleus is still behind, lens nucleus is still sitting here. We are still doing vitrectomy only. After this has been done till the anterior part, then you put in the phaco-frag. This softer part will come immediately, but the harder part will take some time. Believe me, today with the advent of this, most of the hardest possible nucleus also, Niagara also can be, although it may take time, there may be splinters, but they don't damage the retina. You can sometimes use a bubble of PFCl to have a cushion onto the important posterior pole, but engage it and gradually increase the phaco power. Do not, sometimes again it may repeatedly drop, but with patience, with time, it will definitely, all the smaller pieces then will come out faster. So that is the end of vitrectomy, and then this glued IOL, this cortical matter first has to be removed from the behind the capsule. Ensure with wide angle that there are no peripheral issues, no posterior segment complications, no iatrogenic breaks or pre-existing breaks also. Also base vitrectomy is done. And then enlarge this incision and put a IOL, catch hold of. You see this, I think Priya and Amar have taught us very well, this glued IOL technique. And ultimately this IOL is very well centered, and we put that glue and suture it. So learn this art of transformer-assisted anterior vitrectomy, and best is to learn this, trocar-assisted pars plana vitrectomy. Try to preserve anterior capsule, avoid fishing, avoid ghastly instrument like Vectis, and avoid sweeping the vitreous. And refer to a person who is more used to doing such surgeries, and believe me, your patient also will be he will be also happy that his vision has been saved. Thank you very much for your kind vision.
So it was an absolute masterclass for all of us cataract surgeons or as general ophthalmologists to keep these principles in mind. And I can never forget that one sentence which I heard Dr. Steve Charles say once in our course of vitrectomy, that the goal of vitrectomy of a cataract surgeon is to prevent intraoperative vitreoretinal traction. Rest, everything else is secondary, whether the nucleus drops, whether you place the IOL, don't place the IOL. The most important is, if you prevent intraoperative vitreoretinal traction, this patient will do well in the long run.
Absolutely. This word I will also use in the future.
Correct.
Intraoperative, you see, what he said, sever this connection from the anterior and the posterior part, job will be done.
Absolutely.
And possibility of complications will get minimized.
Absolutely. So thank you so much for this wonderful presentation.
Thank you.
So, at the outset, I would like to cover up the entire thing for this instruction course. I'll be covering up not only the retained nuclear fragments, I would also be covering up other aspects that are associated with the posterior capsule rupture. It's actually an honor to see so many people out here at this time. Thank you so much. So, initially, I will be just showing a few animations which, they just explain how things actually work. For example, this animation, it just shows that, okay, when you are doing a phacoemulsification, and suppose if you happen to capture the posterior capsule, do not just directly withdraw the phacoemulsification probe from the eye just because you are scared. The best thing to do at this moment is to press the reflex button, and then you can even start injecting viscoelastic from the side port incision, so that in case even if you have a posterior rupture, it's not going to enlarge. The OVD that we try to use here is usually a dispersive OVD, which tends to seal the posterior capsule defect very well, and only after you have sealed it, you would just pull the phacoemulsification probe out of the eye. So this is one of the ideal situations to handle with. If you have a situation where you have a small posterior rupture, as we showed initially, and you have a vitreous coming up into the anterior chamber, one of the most important things is to seal up that corneal incision, make a side port, have a fluid, and here, if you have a small PCR, I would not recommend, if you're actually not very well versed with vitrectomy, at least do something in the anterior vitreous, cut off that small streaks which are coming up into the anterior chamber, put up a triamcinolone, see how much vitreous is out there, and you can just clear it off. But the situation, the equation completely changes if you have a big posterior rupture out there. Now, when you have a big rupture, I would actually not be recommending to do an anterior vitrectomy. Actually, the pars plana vitrectomy is the most ideal thing to be done in this situation. So you need to have a fluid infusion inside the eye. You can also use an anterior chamber maintainer at this point of time, but you need to make a posterior entry and do a pars plana vitrectomy. The ideal thing is to place up a trocar, shave off the vitreous that is actually bulging into the anterior chamber, and then maybe if you have done that, the limited amount which is there in the periphery, you can clear it up by doing a limbal, from the limbal incision. So maybe you can use a combined approach out here. But the concept of doing a pars plana vitrectomy, as Dr. Shell and as Dr. Lalit Verma has also highlighted, it is a very important aspect. Now, what actually I have seen practically, most of the anterior segment surgeons, they have an inhibition to put a trocar cannula into the system at about 3 to 3.5 millimeters from the limbus. Believe me, it is one of the most simple things that you can do, provided you maintain the method of how to do that. And maybe any of your VR friend can help you with that. So that's one thing which can be very handy. At this point of time, I would just like to ask the audience that how many of you are actually doing a vitrectomy with the vitrectomy probe whenever you have a complication? Okay, so we have quite a bit of people. And is there anybody who is still using the scissors to do? Because all those people who have not raised their hands means either they have not have, I don't believe you don't have a complication. Everybody has a complication at any point of time. So you will need a vitrectomy to do. I think all the surgeons who have just not lifted their hands, they should move into doing vitrectomies if you are a cataract surgeon. Everybody has a complication. If you say you do not have a complication, means either you are not operating or you are just lying. So we just need to accept this fact and move ahead. Well, I'll be just showing this video. Okay, now here, there are multiple situations going on. You have a small pupil, you have a residual cortex, but you have an intact rhexis. So what you actually do here is that, you need to see inside the eye. Without seeing, you cannot do anything. And in this situation, no ring helps you. You have to use an external fixator device, which is an iris hook, whenever you have a posterior rupture. If you put a ring inside, it's going to go behind at any point of time, and then you have one more complication that is added up. Okay, now we have a pars plana infusion going on in this patient, and there is a residual cortex out there, and trying to remove that cortex with the vitrectomy cutter in itself. So now at this point, it is very important that your vitrectomy cutter, you are pulling the cortex, but you should not be cutting the margin of the rhexis, because this margin of the rhexis is going to be very important for you to place the intraocular lens. Now, whenever you are doing this, you have to be very careful of the cutting rate that you have set into your machine and the aspiration rate. The cutting rate should always be higher, the max level that your machine has put it off, and lower down the vacuum level so that you are very safe. The second most important thing is to take up a 3-piece intraocular lens in these cases. The ideal thing is to take a 3-piece lens, you can place it in the sulcus, and you can also do an optic capture in these cases. If you are not very well versed with doing an optic capture, even if you place it in the sulcus, it's very friendly. Please do not, for heaven's sake, place a 1-piece IOL in the sulcus in these patients. The haptics of the acrylic IOL, they lead to the development of UGH syndrome, maybe for some patients, maybe after 10-15 days, for some patients after 1 month, 2 months, 3 months. These patients will come back to you again with complications, red inflamed eye, raised intraocular pressure, and things like that. Always use a tricot injection, inject it inside, and just see if everything is okay, if there is no vitreous strand out there. Have a look at the pupil. I always try to have a look at the pupil because, you might have an irregular shape of pupil out there, because whenever your vitrectomy is not good, your pupil will never be round at the end of the surgery, and you actually do not want to have an optic capture in the post-operative period, because then what happens is that if your iris is flabby, or there's a chaffing of iris, it might go around the edges of the optic of the IOL, and then it might stick with the posterior. Anyway, there's no posterior capsule out here, but with any of the rhexis margin or things like that. So you do not want any entrapment of the iris tissue coming up in these cases. Now, this is an animation. This animation describes the IOL scaffold procedure. Whenever we do phacoemulsification, whenever we have a retained fragments, if you have a good amount of rhexis margin, I would recommend surgeons to do this. Now, there are various permutations and combinations to be applied into this. Always use a 3-piece intraocular lens for doing an IOL scaffold procedure, because at the end of the day, you are going to place it in the sulcus, and then you can use the optic of this intraocular lens as a scaffold, and then you can just phacoemulsify the remnant nuclear material, and then you can dial the haptics of this 3-piece IOL into the sulcus. So this is what actually an IOL scaffold procedure works like. There are various permutations and combinations in this. I would just come up to that in one of the videos. For example, I'm going to show you some worst case things which do happen in the ORs. So this is a case where phacoemulsification is being done, and here you see that the nucleus is sinking. This nucleus is not coming up. I mean, whenever there is no followability of the nuclear fragment, you immediately understand that, okay, now there is some problem in this case. So you need to levitate this nucleus into the anterior chamber. There are various methods of doing this. It was lucky that it could come up from the corneal incision, or else you have to do a posterior assisted levitation, which I will show in the next video. Coming up to this case is that when the entire nuclear fragment or the entire nucleus is brought into the anterior chamber, just take a 3-piece intraocular lens and you inject it behind this nuclear fragment. You have to be very careful when you do this, because you also need to protect the endothelium at this point of time. Now, doing an IOL scaffold procedure, there are many times, for example, in this case, it's so hard nucleus out there. You actually do not see the leading haptic where it is. And whenever in doubt, when you have a trailing haptic, tell your assistant to hold it, because this intraocular lens should not slip and go back into the posterior cavity. Alternatively, many surgeons, they just inject this intraocular lens onto the sulcus, because if you know your rhexis is very good, you place it on that and then you can emulsify. Alternatively, they also put the leading and the trailing haptic onto the surface of the iris, and then they do it. So it all actually depends upon the clinical scenario that you are actually having during the surgery. But in this case, nothing was seen. So it is always ideal to have a part of the haptic held so that you do not have any slippage. Now, this is not what I would recommend it, that, okay, you are done with the nucleus, so you are done with the surgery. No, there are many other aspects to be taken care of. In this particular case, you need to go and also remove the remnant nuclear material which is there around this intraocular lens, and also something which has fallen behind into the vitreous cavity. Now, coming up to this aspect, suppose if you are an anterior segment surgeon and you are not very well versed with posterior segment, I would request to halt the surgery at this point of time. You can place your intraocular lens into the sulcus and you can immediately refer the case to your VR colleague if you cannot handle further, because vitreous is something that we all need to be very careful. There should be no ego in sending your patient to a VR surgeon, because now the remaining thing it's not done by the anterior segment surgeons. It has to be taken up by the posterior segment surgeon. Need to be very honest with yourself and also with the patient. So that is a very important thing. You remove the remnant nuclear fragments which are out there. And having done that, this is one of the most ideal things to do whenever you have cases like this. So this is one thing which I would always recommend. And then you would just remove the iris hooks, check the stability of the intraocular lens, because this intraocular lens is placed onto the sulcus, hydrate the wounds, and just check if everything goes off okay with these cases. So now this is a case which went off, and the patient had a very good recovery in this patient. Okay, now this is one case which I'm just trying to show you what actually is being done here. Now here there is a retained nuclear fragment. This fragment is not going to come up in any way. So when you put a trocar 3 millimeters from the limbus, already flaps for glued IOL are made in this case. So what we try to do here in this case is that you need to levitate this into the anterior chamber. You insert a rod from the trocar and try to bring this nuclear fragment into the anterior chamber. Once you get this nuclear fragment into the anterior chamber, then you have a different modality of how to go ahead and handle this case. Now this is actually what is happening here is that we need also to do a secondary IOL fixation. So the procedure of choice is always a glued IOL procedure, trying to cut off all the vitreous which is behind this nuclear fragment. Because when you are injecting the intraocular lens, you do not want any dragging of the vitreous happening. So try to play safe as much as possible. But again, this technique can be done only by people who are actually very well versed with doing a glued IOL procedure. Because this procedure, I would not recommend anybody doing it if you're actually not very well versed with the handling of the haptics, externalization and all, because it's not that easy to do. So this is the leading haptic which has been externalized, and then this is the trailing haptic which is being managed. It goes from left hand to the right hand. It is the handshake technique. Nothing is seen. It's only the experience and the tactile sensations between both the hands that okay, now your left hand has hold the haptic, and now you can free off your right hand, again go back from the sclerotomy site, again hold the haptic, and then pull the haptic from that side. So then you have this, this is a small trick, there is a small area where you have a visibility, so you can hold the tip of the haptic from that area, and then you can just pull off the haptic. So once you have both these haptics out, you can tuck these haptics. We also use the iris hooks, the plugs of the iris hook we often use to slip onto this haptic so that it does not slip anywhere. The IOL and the haptic remains as it is, and when we are done with all the manipulations inside the eye, then we go ahead, release those things, and then we tuck the haptics, and then the things they get settled. But here in this case, only direct setting has been done. The haptics are they are just tucked into this, and then you have this fragment which is there into the anterior chamber. So now then you can just emulsify this nuclear fragment, and then be very careful. Actually, if you have a small pupil here, it is very beneficial because it prevents the slippage of any nuclear fragment from around the edges of the optic of the intraocular lens. But anyway, there will be some slippage or some cortical matter which will still be there behind. So again, you will always need to do a posterior vitrectomy in these cases, because you're not very sure of how the things are going on. But at any point of time, I would like to say that you need to coat the endothelium very well in these cases. This procedure is not recommended if you have a low endothelial count, or you have a very dense cataract coming up, or a dense brown kind of a cataract coming up. The best thing is to maybe just extend your incision and get that hard cataract outside the eye. Another principle is always seal the corneal wound whenever there is vitreous. You should never, even if you have done a good vitrectomy, never leave the corneal incision as it is. You need to take a suture, seal up things, put up a fibrin glue, and do up the things. So anyway, I would like to show you much more interesting something for the anterior segment surgeon. So now have a look at this. This is an Ozurdex injection. This Ozurdex injection was injected and there is a posterior rupture. It has not gone into the vitreous cavity. It has not gone into the vitreous cavity, and it has ruptured the posterior capsule, and it lies within the lens. So I'll just forward this a bit just for the benefit of all. You do a Rex's, and this Ozurdex, anyway, it comes up very easily into the phacoemulsification probe. You do a good IA at this point of time, but you know that you have a posterior rupture. So go very, very slow when you already know that this element is there into the anterior chamber, and you are going to expect a certain amount of posterior capsular dehiscence in this patient. So carefully and diligently doing an irrigation aspiration in this patient, most of the cortical matter is just removed, but yes, now things have started to show up that, okay, there is going to be a small opening out there, but it seems that there is no frank vitreous that has come up, but yes, there is an opening out there. So now this is a point. You should not be fishing at that point because the vitreous is already there. So best thing is take up a vitrectomy cutter and try to do a vitrectomy. Now if you do it, this is the difference. When you do it from the limbal vitrectomy, you're never satisfied because the vitreous keeps on pulling and coming into the anterior chamber. But when you go from behind, you shave off everything which is bulging into the anterior chamber, use a triamcinolone, and then you will see each and every small strand which is there into the anterior chamber, and then maybe you can clear up things which are there into the anterior chamber. So having done this, and clearing up everything out there, then you are free to use, your intraocular lens. Anyway, I would always recommend, whenever you are taking up any challenging case, have a 3-piece intraocular lens standby, because you actually do not know when you would actually need it. And what happens is that actually I have seen surgeons, you do not have a 3-piece IOL standby, and so what happens is that, you are forced mentally that, okay, I have to put the lens somehow, what will I go and tell to the relatives? Nothing of that kind, because that becomes a very tricky situation. So I think it is best to have the stock of 3-piece intraocular lens, few lenses into your armamentarium. They can be really helpful to you whenever it is actually needed. So this patient actually behaved very well in the post-operative period. This is one case, I would I'll just see the time. Okay, I'll just 5 minutes more. Okay, this is a case which was again a referred case. This patient had a very high refractive surprise, because patient was probably operated when the patient was a kid. So we need to explant this intraocular lens, but YAG opening was there and there was a lot of fibrosis out there. So what I'm actually trying to do here is that, trying to remove all the adhesions which are there around. And actually I had decided that, maybe I will cut this intraocular lens. So I take up the IOL cutting forceps in this, but then I eventually realized that, okay, this intraocular lens is a PMMA IOL, and there is no way I can cut this intraocular lens with any of the forceps that I would actually have. So the best thing is to just explant this intraocular lens. I had to enlarge this incision at this point of time, and then, I just removed this. But there is a fluid infusion going on in the eye at this point, and that is a very important thing. And then I would just take in and replace it with a 3-piece intraocular lens, which is placed into the sulcus. What actually is important in these cases is that, this eye had, nevertheless, we did a refractive exchange for this patient, but there was a very persistently dilated pupil also in this patient. So it was very essential to do a pupil repair also in this case. So this is what I'm actually doing, is the single pass 4-through pupilloplasty procedure. So this is a 9-0 polypropylene suture, which we take up, and I'm trying to close this from the, trying to pass this from the anterior and the posterior and the proximal side, and then this is the loop that we try to withdraw and hold it with an end-opening forceps. We pull it out, and then we take up 4 throws. So this is the principle that it actually helps to do a pupilloplasty procedure in these situations. In these situations, actually, it is also very important to do a pupil repair. Many times it is for photophobia, many times it is for cosmetic reasons, many times it is also to prevent any optic capture coming up in the post-operative period. So I think this is very essential for everybody to learn how to do a pupil repair as and when it is actually needed into this. And another important thing, advantage of doing a pupil repair is that, actually it acts as a physical barrier between the anterior and the posterior chamber. Like, for example, in this case, you have this intraocular lens out there. So now you have those periphery open. If you have that periphery open, whenever you do a pupil repair, it closes down. So there is an anterior and the posterior demarcation which comes up. And I have seen many cases, they also have endothelial decompensation. So this is again where a pupilloplasty procedure works very well, because it does not allow any vitreous to come into the anterior chamber, and the success rate of an endothelial keratoplasty procedure being done at a later stage, it increases massively, because you do not have any vitreous in the anterior chamber. So that is one of the another benefit of doing a pupil repair, specifically in these cases. So this is the single pass 4 throws taken, always taken in the same direction, and then you just pull both the suture ends, and then it beautifully slips inside, and then you can just cut them off. So you take up an end opening scissors or a long arm scissors, whatever you have into your system, and you can cut that suture. Always stain. I have a habit. I always use a triamcinolone at the end, and always to make sure that everything is going okay inside the anterior chamber. So these are, I think, some of the things that I would just like to share. I think I would like to stop here, and I would like to invite discussion from people, although I have lots of presentations pending, but I think we should be having some sort of discussion coming up.
Absolutely. Dr. Priya, excellent array of cases. I just have one reservation with the IOL scaffold, particularly in the cases that you had showed. Would you, I mean, particularly when you're doing a 3-port pars plana and you're going to do a posterior vitrectomy, do you think it would be safer to do a lensectomy from behind rather than dragging the nucleus in front, putting an IOL behind and doing a phacoemulsification above it? Because, like our cataract surgery outcomes have improved, I think the lensectomy outcomes are equivalent to almost phacoemulsification.
Absolutely.
Yeah.
For the lensectomy, I would like to say that, yes, if you have a soft, I didn't show that video.
Yeah,
If you
correct.
have a comparatively softer nucleus, it's very easier to do a lensectomy from behind. And it is actually advisable
Correct.
because you shave off everything from there and everything gets clear from there. But when it comes up to a very hard nucleus, whether you are doing anteriorly or posteriorly, I would like to have know what Dr. Gadre wants to say. I see him smiling. But the point is that, whenever you have a dense nucleus and even if you have it into the posterior cavity, you have to have some methodology
Absolutely,
to
yeah.
remove that. So maybe, yes, maybe a posterior segment would do a phacofragmatome or something of that kind, and maybe for us it would be better to get it into the anterior chamber and then we can manage it into our own system.
Absolutely. And I think the most important take-home message that I've learned from this entire course is never swipe your wound. So the habit that we have, that let me swipe the entire pupillary area and let me swipe at the incisions to see if this pupil is becoming round or not, that causes the maximum amount of intraoperative vitreoretinal traction. So whenever in doubt, just put diluted triamcinolone, just put BSS, and the vitreous will get stained, rest of the part will wash out, and that's the best way to find out if there is vitreous stuck in the wound or anywhere in the pupillary area. I think that's,
Absolutely,
yeah.
absolutely. Any questions, please? If anybody has any questions, please use the mic to ask. Can you please switch it on for them? Yeah.
So, just your management for macular edema in such cases.
So I think these patients are going to require more anti-inflammatory treatment, and it may require anti-inflammatory as well as IOP lowering in the early post-operative period due to inflammation. So these are the cases where along with I kind of use topical steroids, prednisolone acetate. So even if you're normally using dexamethasone, this is the eye where you want to use prednisolone acetate for maybe at least 6 weeks, tapering over 6 weeks, and I would not hesitate to continue using the NSAID eye drops like Nepafinac or Bromfinac or whatever molecule that you're preferring for at least 8 to 12 weeks post-operatively.
Absolutely.
So, Dr. Priya, I had reservation for the case in which you used IOL as a scaffold in a brown cataract. So, I would recommend that either you take out the nucleus in toto by enlarging the wound or converting the wound to a SICS wound. Doing phaco in such a brown cataract in AC would compromise the endothelium.
That is what I said.
Yes.
That actually you have to pick up what you actually want to do and what actually you are well versed with and what actually you can predict that how this surgery will unfold into your hands. Otherwise it is always safer to just extract the
Yes,
the
you can
intra-
enlarge the wound,
foam.
put few sutures.
Absolutely.
That's
you can
a
make
better option.
You can make a scleral incision, you can enlarge it and then seal it and then do a vitrectomy, then fix up the IOL, so that it can go that way also.
Yes.
Yes.
And I think another most important take-home message is that you must have a 3-piece backup. So, one thing that we follow when we order an IOL, we always order a backup 3-piece IOL along with it. We return the 3-piece at the end of the day once the cases are over and it's not being
But
used.
Salish, you did not show any case with 3-piece IOL. In all your cases, you manipulated the
so-
posterior capsule,
Correct,
converted into rexes and tried to place
Yeah.
single-piece IOL in the back.
Yeah.
So
in
not
cases
all
where-
surgeons are that much talented. So you should show the
Yeah, absolutely.
simple
So
procedures.
3-piece is something that we must have, and the safest option is to put, like Dr. Priya showed, 3-piece haptics in the sulcus and capture the optic through the anterior capsular rexes. And like Dr. Priya mentioned, that even if you are not able to capture, say if there's an anterior
Yes.
capsular split, if you put a 3-piece in the sulcus, it's going to behave very nicely if you take care of the early post-operative inflammation.
Absolutely. Any other questions? Okay. So I think we are done with our time and all. So thank you everybody. Thank you, Dr. Shell, for being here
Thank you.
with me till the end. Thank you, everybody. Thank you so much.